Epilepsy in women. Approximately 1% of the population has epilepsy, making this one of the most common chronic health conditions affecting reproductive-aged women. The prevalence of epilepsy and approach to treatment are similar for men and women. But there is a lot to know about epilepsy, if you are a woman. Women with epilepsy are more likely to experience seizure patterns that relate to reproductive cycles and are at risk of reproductive health dysfunction and pregnancy complications. The female hormones estrogen and progesterone alter excitability of neurons of the central nervous system. Estrogen increases and progesterone decreases the likelihood of a seizure. Women with epilepsy may experience changes in seizures at puberty, during the menstrual cycle, and at menopause. Childhood absence, petit mal, and benign partial epilepsy with centrotemporal spikes, Rolandic epilepsy, usually remit at puberty, but partial seizures worsen after puberty. Juvenile myoclonic epilepsy is a common epilepsy syndrome occurring primarily in women at puberty and characterized by absence, myoclonic, and tonic-clonic seizures. Juvenile absence epilepsy, characterized by absence seizures, also arises at puberty and is more common in women. 30 to 50% of women with epilepsy experience catamenial, menstrual cycle-related, seizures. Seizures are more likely to occur near the time of menstrual flow because of progesterone withdrawal and with the estrogen surge at ovulation. Seizures are more random and severe during an ovulatory cycles because the ratio of estrogen to progesterone remains high. Hormone-seizure relationships have led to interest in hormonal therapies. High-dose progesterone has shown some success. Women receiving a liver enzyme-inducing antiepileptic medication have at least a 6% failure rate per year for oral hormonal contraceptive pills. Most commonly used oral contraceptives contain 35 micrograms or less of estrogenic compounds and may be ineffective in women who take some antiepileptic drugs. Women taking enzyme-inducing antiepileptic drugs should use non-hormonal methods of contraception or receive contraceptives containing 50 micrograms or more of the estrogenic component. Fertility rates in women with epilepsy are reduced by 1 to 2/3 when compared with their non-epileptic females. 1/3 of women with epilepsy have an abnormal menstrual cycle length, less than 23 days or more than 35 days. Reproductive endocrine disorders in women with epilepsy include disturbances in luteinizing hormone, abnormalities in prolactin and steroid hormone levels. Pituitary hormone abnormalities are probably associated with disruptions in hypothalamic input to the pituitary as a consequence of seizures. Valproate is associated with elevations in testosterone levels, polycystic ovaries, obesity, and insulin resistance more often than other antiepileptic drugs. This is reversible when the medication is changed from valproate to lamotrigine. Polycystic ovaries are described in 20 to 40% of women with epilepsy. These women often have an elevated body mass index of more than 25 kilograms per square meter, hirsutism, abnormal menstrual cycle length, and anovulatory cycles. A reduction in sexual desire is reported in 1/4 to 1/3 of women with epilepsy. Social and psychologic stresses of living with epilepsy may be an important factor in these higher rates of dysfunction. Seizure frequency is increased during pregnancy in about 1/3 of women with epilepsy. Women with epilepsy have a 4 to 8% chance of giving birth to a child with a major malformation, compared with 2 to 4% in the general population. It includes neural tube defects, cleft lip and palate and ventricular septal defect, associated with exposure to valproate and carbamazepine. Minor congenital anomalies affect 7 to 15% of infants. This involve the face and digits, including hyperchlorhism, epicanthal folds, broad nasal bridge, elongated philtrum, distal digital, and nail bed hypoplasia. The risk of teratogenicity is significantly increased in women taking multiple antiepileptic drugs and in those on high doses of antiepileptic medication. The American Academy of Neurology advocates single drug therapy at the lowest possible dose that effectively controls seizures. Folic acid supplementation should be provided to all women of childbearing potential. Prenatal maternal serum alpha-fetoprotein test at 15 to 20 weeks of gestation and an amniotic ultrasound at 16 to 18 weeks of gestation detects many of the congenital abnormalities. The American Academy of Neurology recommends that the mother receive 10 mg of oral vitamin K per day during the final month of gestation to reduce the risk of neonatal hemorrhage. Breastfeeding is advocated for women with epilepsy. It is advised that the breastfed infant of a mother receiving anti-epileptic drugs be observed for irritability, poor sleep patterns, or inadequate weight gain. The benefits of breastfeeding are felt to outweigh the potential risk of continued exposure of the neonate and infant to anti-epileptic drugs. Thank you.